welcome to the Psychiatry and Psychotherapy podcast. I'm here to talk about getting rid of burnout, increasing job satisfaction, and feeling like an expert in what you do. One thing that created a lot of burnout and angst for me was trying to get continued medical education right at the last minute. So why not join the CME membership and do CME while listening to this podcast? Go to psychiatrypodcast.com, sign up, sign in, take the test, and the certification is emailed to you in seconds. All right, welcome back to the podcast. I'm joined today with Craig Heacock, Dr. Craig Heacock. He is a psychiatrist working out of Colorado, and we did an episode for his podcast, and I am having him on my podcast to talk about treating VIP patients that either consider themselves to be VIPs, or maybe as medical professionals, we feel like intimidated, or we feel like we're giving them special treatment, or we feel like a little bit more pressure. Often it's people that we sort of are consciously assessing are high up the dominance hierarchy, maybe high up. And this could be specifically the dominance hierarchy of your liking. So if you were into classical music, this could be, Yo-Yo Ma comes into your office for anxiety and you're a therapist, and it's like, this is someone you worship, and now he's right there. Obviously, if you don't know Yo-Yo Ma, you don't know classical music, this could be perceived in your mind as someone who thinks he's a VIP. I don't know Yo-Yo Ma, so maybe he comes in thinking he's a VIP. Maybe he just acts pretty normal and you don't think he's a VIP at all. So we were talking on your podcast a little bit about how you've treated physicians, colleagues, and there's a kind of unique aspect when we start to see someone very similar to ourselves as well. That's kind of like, we can kind of change the way we do things. So I thought that I would have you on and we would have this topic.
Yeah. Thank you, David. First of all, I want to apologize. I'm on the Front Range of Colorado, and the smoke here from California has been so severe that my asthma is kicking up and my voice is really scratchy. So I'll do my best to be coherent. But for those of you who haven't listened, David was on my podcast, Back from the Abyss. We did an episode called The Clinical Moment in Psychotherapy, and I think it turned out great. And yeah, this was one of the interesting topics. We talked about doing therapy, doctoring VIPs. And I guess I really love this topic because we got some training in residency about difficult patients. But I think, as you and I talked about in my podcast, some of the most difficult patients are VIPs. And you and I talked a little bit about physicians in particular, because not all of us are going to treat Yo-Yo Ma or, a famous politician, but probably we're going to treat physicians. And because of transference and countertransference issues and specialty hierarchy and our own stuff, as you just mentioned, like just the act of treating another physician as a psychiatrist can be fraught with danger. And
yeah, there can be, I want to just highlight your podcast, Back from the Abyss. It's psychiatry and stories. It's a much more conversational sort of dialogue, listening to people than my podcast. I have some of those things, but my podcast is kind of more geared towards the mental health professional. But yours is Back from the Abyss. The title of that is, this is your journey out of your own sort of abyss that you found yourself in at one point. Is that correct?
Yeah. So I had my own really difficult stretch early in my career with addiction, where I just fell into just such despair after a number of suicides, and I was getting increasingly overwhelmed with my practice. And then I went into my own abyss and came out. And then a few years ago, I started getting obsessed with podcasts, and I started thinking, I want to help people tell the story of their own darkness and how they came out. And so that was the idea of Back from the Abyss, is this sort of plunge into the psychiatric or psychological abyss and how they got out with the goal of spreading hope and letting people know that even in the worst of darkness, that there's a way out.
Yeah. Yeah. So you both have treated physicians and are a physician who has been in treatment. I'm a physician who has had my own treatment. When you were receiving treatment, did you feel like the person treated you differently because you were a psychiatrist, because you were someone known in the community as a psychiatrist?
That's such a good question. I remember when I went to treatment, when I first was evaluated and then went to rehab, I wanted them to treat me specially.
Yeah.
Because I was being evaluated by a psychiatrist, an addiction specialist, which is what I am. And I wanted them, and I don't think I consciously thought that, but I thought, you need to give me some slack. You need to treat me different because I'm clearly different from all these other people because I got it together. I know what I'm doing. I'm an expert. And, to her credit, my psychiatrist treated me exactly, I think, like she treats everyone else. And I was furious. I was resentful. It took me a long time to really work through this idea that, hey, wait, she just taught me a really valuable lesson. One as a patient, but a bigger thing as a physician is that people are going to come to us and consciously and unconsciously want to be treated differently for a lot of reasons. And it was interesting to be on the other side of that, to be furious that I wasn't given special treatment or special favors.
Interesting. Yeah. So in my role as a psychiatrist, I've treated a number of medical students, residents, physicians. I've also, like now in my sort of with the podcast, I don't know, have you found that more people reach out to you than before who might consider themselves VIPs or are VIPs?
Yes, for sure. Yeah, it's kind of thrilling to have VIPs contact you. And already I've seen that it's so hard not to bend the rules. People say, oh, would you meet me after hours? Would you do an out-of-state Zoom session? Would you start me on this medication, but then I'll see you later? And others. And, it's such a mix of knowing I shouldn't do this, but I want to do this. I want to please the person. I think especially with the physicians, I treat a number of physicians and they are constantly asking me for special favors. And some of them found me through the podcast. In fact, just the other day, I got a call from a guy in New York City who wanted to see me, but he's in New York City. I said, look, you live in the land of psychiatrists. You should find someone on the Upper East Side. But he wanted me to treat him remotely. And I was really tempted to because he was kind of a bigwig. But I thought, no, I just had to tell myself the best care, he needs to be treated there. It's not like he's in rural Alaska. But when people reach out and ask, it's tempting to say, oh yeah, for sure, I'll work with you. So I find I'm constantly having to ask myself, wait, is this best for them? Why am I saying yes or no? And what are the motives?
Yeah, so that I've had to kind of check my internal clock as well, and I think that's why this is it's interesting because I think that it does affect your countertransference, the total reaction we have. And so I was digging into the literature a little bit, which I'll sort of bring out and ask your comment on these things. So it's kind of been in my mind. And then when the Britney Spears thing came up, I did an episode on that with a lawyer and with this psychiatrist who's treated baseball players, and kind of this VIP topic came up, but I felt like we didn't really flesh it out. So I was like, man, I gotta talk to Craig and get your take on your experience here. Okay, because we have you here, man, what is like some of the harder things that have come up in treating physicians?
So, gosh, I've treated a bunch of physicians. One was a really difficult case, and I'll change some of the details. I'll do that with all these, but this was a very successful physician who had bipolar 1 and mostly did well, but when he would decompensate, he would get psychotic and homicidal. And he ended up losing his medical license. And he finally got stable after working with me. And he begged me to write a state medical board and to alter the record. And his lawyer had a letter to me that said, if you will change this one thing in the record, he can work again. And he cried and begged me in my office. He was actually younger than me. He had a family, had children. He said, I can't support my family. All you need to do is write the state medical board and just attest to this one thing that's not true. And I didn't do it, but he fired me. And I still think about him. And that's a more extreme example, but I have physicians regularly ask me for controlled substances without seeing them, to see them after hours, to not hospitalize them when they're suicidal. And I really think, at least I've seen some famous people and some well-known people, but for me, and you and I talked about this on my episode, doctors are the hardest because we identify with them. They know just enough psychiatry to get themselves in trouble. And we don't we see ourselves in them. Or like, for example, I treat a couple anesthesiologists and a couple surgeons. There's this hierarchy in medicine, and I kind of think, well, you're like the surgeon, you're an anesthesiologist. So it's hard as a psychiatrist not to feel like we're kind of outside of the realm of some of those super specialties. And sometimes I find myself deferring to them or even their judgment and having to say, wait, they're not trained in psychiatry. They are incredibly well trained in their specialty, but this is like med student me looking up like, oh, you're a big deal surgeon, or you're this big deal specialist. When really like, wait, they came to me because they need help in this area, but just assuming that they have competence, not just in their area, but competence in psychiatry, when actually usually they don't at all.
I imagine it's frustrating for you to then realize like, okay, I'm deferring to them. And it's because I like consciously, unconsciously, like look up to them or see what their work is very important, which kind of almost takes away like your entitlement to your expertise and your years of, like 30,000, 40,000 hours of practice. I don't know, maybe more than that at this point.
Yeah. But I wonder, I think at least for me, treating, procedural specialists, for example, sometimes I've had a little existential crisis. Like, what are psychiatrists good at? We don't sew, we don't have scopes, we don't do funky interventions with stents. We talk to people, we listen, maybe we give them ketamine, but our skill set is deep and rich, but it's hard to put into words. And I think sometimes when I'm sitting across from a super successful, specialty surgeon, it's easy to think like, oh, like she's a real doctor. She's the real deal. She's the head of this huge surgical center, and I'm sitting here alone in my office with a couch talking to people. Like, and then I can talk myself out of that. But it is interesting how, because I got a lot of messages in my medical school that psychiatry was less than. That if you went into psychiatry, it was like a default for people who don't want to be real doctors, which I couldn't disagree with more. But I do find, sometimes when I'm sitting across from a physician, I sort of go back to that space of like being a third-year med student and having people make fun of me for saying I want to be a psychiatrist. Or,
I wonder what kind of mirror neuron stuff you're picking up that would lead to that insecurity. And so part of my research, I did like this connection index, which looked at the connection that residents felt towards their attendings. And in the process of doing that, in one department, surgery or anesthesia, I'm not going to say, I went through and I did all the attendings, and then I met with the attendings and gave them their feedback. And some of them were rock stars, but some of them were interpersonally abrasive and like almost like low EQ, low social EQ, right? Needed to improve their EQ, but like maybe their ego got in the way of that, or their stress or whatnot. And some of them scored low because they were going through a lot of stuff like a divorce or child custody battle, or there were like reasons that were stressing them out, and so they weren't as connected to the residents. But some of them had personality issues. But I'm wondering if some of the people that you met with, it's almost like you felt their profound insecurity, and then we feel that insecurity, that profound insecurity, but then we put our own narratives on it. So the narrative that you put on it is the narratives from the past, right? That related to them and you and your specialty. What do you think?
Yeah, no, I think that's totally true. I mean, that's one of the reasons I think you and I and so many other people just love therapy and psychiatry in the mind is it's never just about what's happening in the room. I mean, it's that, and then it's the past, and it's what's being triggered, and it's the layers. It's the past relationship templates. Like it's like Inception. There's all these layers. And for sure, I think it's very likely that someone comes in as a little cold or hard to reach or just like a restricted affect. I'm thinking like, oh, yeah, you are not thinking I'm competent, or you're discounting me, or it's because I'm a psychiatrist and you're a specialty surgeon and you already think, yeah, that I can't possibly help you because who in your med school class became psychiatrists? And right, that's all me. Like I'm coming up with this narrative. And I think, again, this is with difficult patients, including physicians, we get this stuff triggered so much that just starts flying through our minds and our bodies. And it's hard to give people good treatment because we're just playing out our own scenarios.
So I did this episode with David Burns, and I was vulnerable. And at one point in the episode, I said, I don't know if people want to hear this vulnerability on my podcast. And David Burns was like, all right, guys, if you heard that, if you like this, email Dr. Puder that you liked it. And I got like hundreds of emails. And I'm thinking about, you're being vulnerable here. And some people might not understand that, like to just put out your insecurities and stuff. But, psychiatrists are real people too, right? So we're sitting there, we're treating people, and we can have these sort of things that we need to work through, need to be curious about. And I think that rather than have judgment that we have these thoughts, if you have these critical self-thoughts during sessions, which I imagine a lot of my audience has from time to time, just imagine if you didn't have that in your conscious. And if you had it unconsciously going on and weren't registering it, then you couldn't be curious about it. You couldn't look at the meanings of it. We couldn't look and think oh, maybe it's this physician's insecurity who's coming in for the first time seeing a mental health professional. Something must really be off, right? Something must really be bad. Physicians are very resistant to getting treatment. And
we're terrible patients.
Physicians, I would say residents actually have lower suicide rates than the general population. Residents it's about 4 per 100,000, whereas in the general population it's around 11, or 13. So for that age group, we are more resilient. But then what happens as physicians age is it's like the cumulative burden of stress kind of weighs on us, right? And we have decades and decades of patients dying and horrible interpersonal situations in our personal life. And we may have an incredibly busy schedule that it's hard to get in to see a doctor or a therapist, or we may not want to, right? So I'm curious, what have you seen as some of the points of resistance in these VIPs and getting the treatment that they need?
I think one of the most common things I see is that VIPs, and doctors included, can be really resistant to actually come in and see me. They want to be treated by phone and text. So I have a number of people who are super successful, or a few well-known people, and my doctor patients. It's they say, hey, I'm busy. Can you just, do this, but they don't want to come in and sit down face to face. And, it's kind of exciting sometimes to get a text from certain of my patients. I think, wow, that's cool. They're texting me. Sure, I'll do what you want. But then I think, wait, is that good care? You need to come see me. And then I say that you should come see me. Oh, yeah. And then I think, wait, would I accept this from other people? But then you don't want to upset them. And then again, I think if we go back to physician-patient, I recognize how busy I am and how much I can have trouble saying no to taking on new people. And so I could put myself in their shoes. Oh, they're too busy to come see me. I should probably just treat them sort of by a 2-minute phone call and text check-in. That's terrible. So that's the biggest thing I've seen, is that docs and some of my other VIP patients just they want to have just very remote, tip their toe in treatment. Okay, now I'm pulled out. Hey, are you there? Okay, we're good. Versus, the sort of face-to-face that I insist on with everybody else.
Yeah. I think we all would like solutions that are very fast, but often the best solutions are very slow and take time. And I would say one of the difficulties that I see is kind of this commitment to the weekly work of therapy, or twice a week. And then it's really management of shame, because just because someone is successful doesn't mean they don't experience a lot of shame. And some of the most hardworking people are hardworking because of the shame. It's the shame of being found out, or the shame of, or the perfectionism that comes with that kind of drives them to these accomplishments to try to prove against their own sort of inadequacies. And
yeah,
so
I think that's true, David. You have to think of, just off the top of my head, 3 different physicians who pop in my mind who I see who are really phenomenally successful, and they're driven by shame, trauma, just awful stuff in their early lives. And so what they learned was, succeed, succeed, succeed. And, if you run fast enough on the treadmill and you work, 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 then maybe you can run away from your past. And I was just thinking the other day, I see a guy, specialist, really successful, and he deeply needs to see me very often. I saw him the other day. He said, "So 6 months, is that what we'll do?" I said, 6. He's like, "Yeah, I'm busy. How about that?" I said, "How about next week?" He said, "How about 4 months?" I said,
Yeah.
I know. And
Yeah.
so, I laughed and he laughed, but that is such a classic, at least what I see, especially with my physician patients and you think busy business people too. Like, yeah, they want this, like, come in, boom, fast food, fix it.
Yep.
And then we'll just stuff it, make it go away.
So one of the fast foods of psychiatry is benzodiazepines. And one of the things they found on autopsy of physicians is that physicians have a odds ratio of 21 that they were taking a benzodiazepine compared to the general population.
Wow.
And antipsychotics was 28.7, which may be because they're being treated for something like bipolar or something like that, or I don't know why that's so high. That I'm curious about that. That was in a study, Gold, 2013. A lot, I think, like there's a lack of knowledge in a lot of physicians, since we're talking about physicians, of the value of long-term therapy, like once-a-week therapy. Like I had this one guy who came to the end of our 6-month stint of therapy, and he attributed the success of his change to something not therapy. And I was a little bit like the word I'm going to use is castrated. Mm-hmm. It was like, mm-hmm. it was a little bit of a jab at me maybe, but it was also like, there's some things that are concrete that it's easier to point the finger at. Like, oh, I changed my diet, or, oh, I started, this new medication. And then magically after 6 months of taking it and weekly therapy, I attribute it to the medication. So sometimes there's a lack of understanding of the value of therapy, that it's almost like hard for anyone to really understand. But then VIP people who's maybe it might be a harder pill to swallow. How do you get someone to really commit to the weekly therapy who maybe is resistant to it?
Yeah. I've used a few different strategies. One strategy I've used is to bring in spouse, if they have a spouse. And I mean, I usually do that anyway, just to get collateral information. But a lot of times the spouse can say, "Hey, other spouse, you need Craig, you need Dr. Heacock. Please come, like, do this for me." I've actually had that with a few just overall VIP and physician patients where when the three of us met, that was helpful. It's like the spouse could call the bluff because, the physician shows up like, "I'm fine, I'm good. I'm handling this well. I'm not really drinking that much, and I'm not really that suicidal, and I'm doing my job." And the spouse comes in and says, "Nope, not happening." And I also, I try to make explicit, what this whole difficulty of treating physicians. I'll talk to people early on and say, "Hey, this is a tricky relationship." Both being docs, like you would think that we would be especially good for each other, but there's some reasons that we might be especially difficult with each other, and I'm going to watch for those. I want you to watch for those, and I think people appreciate that. It's interesting. Like, I often worry that if I bring up those kinds of, countertransference issues with people, that, hey, this is going to be hard for me because of X and Y, they really appreciate it. Again, it's sort of like you said, when you have admitted to vulnerability on your podcast, and I know that's true in my podcast, like, our patients, they want to know that we're real, that we're self-analyzing, that we're vulnerable, that we are thoughtful. They don't need us to be perfect. They actually want us to be human.
Yeah. I think it can be a skill to know when to be vulnerable with patients. I think I've heard it go wrong from a number of therapists who I was like, talking to, and they were like, "Oh, the therapist disclosed this thing," and it's like the first session. So I think I was talking to, or a resident the other day about this, and I said, maybe after 6 months they earn some degree of vulnerability. That being said, if I'm really tired someday and they're picking it up, and if they're someone who would then take it upon themselves, like, oh, I'm boring, therefore he's tired, I may reveal like, hey, just want to let you know, going through some stuff, and I didn't get quite as much sleep as I normally do, and just to kind of give them it's kind of a mentalization type thing where they can mentalize like, okay, that's why it's going on,
But I think ultimately, though, if we can get people, I'm thinking again, my physician patients, if you can crack through this kind of barrier that they need to look okay and be okay, they can relax. Many of them can just relax into this just deep gratitude for being taken care of. You may have seen this, but some of my physician patients, after a while, they come in and they finally just like settle into the couch and just like, and they just relax, and they just let it all be. And I can tell they no longer have to be the super achieving specialist. They can just be real and cry, and that's so powerful. I think when we get to that level. Yeah. Even our problematic physician patients can get there.
And I think it's important to say part of the reason why they're problematic is because it brings up stuff for us. It's close to home. Mm-hmm. It's like when you're treating someone and they have a daughter who's like your daughter who's going through some stuff, or they have, it's like when there's that parallel process, which is it increases our empathy, but then it also can get us out of their experience into our own experience. And we need to kind of like work through that. Specifically with physicians, I was thinking there was one study that asked, about board requirements. And, there's a lot of very invasive, backwards board questions. Like when you're, applying for a license in a specific state, like, have you been under psychiatric treatment, or have you taken medications, or have you seen psychotherapy? And in one survey, 75% of respondents agreed or strongly agreed that medical licensing board questions about whether a physician has ever had mental health diagnosis or treatment impact decisions about seeking treatment. Mm-hmm. And so what I found, so I offer like coaching. I have a nonprofit where I specifically offer coaching, and because of my sort of interest in medical education and some of the research I've done on connection, I run all my physicians not in state through that system. And if they're suicidal and if they need medications, I'll, help them get through the resistance of seeking that care, obviously. So there's certain things I won't treat under that coaching relationship. But what I've found is that there are a lot of physicians who are so scared about not being able to work that they will not seek treatment. Mm-hmm. They won't seek treatment at all, until it gets so bad, right? When like their life is in jeopardy. So I didn't expect this kind of direction of the podcast, but here we are, and we're thinking, so imagine you're talking to a group of physicians. There's some 30,000 mental health professionals who listen to these things. What do you say to encourage them to not feel shame in seeking the treatment that they might need as a VIP?
Yeah. I think one thing, when I first meet with medical professionals is I talk about my notes, because a lot of people are worried about what am I going to put in my notes. And, even as I'm going through the eval, some of the more sensitive questions, if I sense people, physicians or other VIPs are really sensitive, I might say, this is something I don't have to put in the note if you don't want. And some people really appreciate this idea, because I've had people open up to me either in the initial eval or later, and they stopped. And if I brought up this idea that it wouldn't be in the record, that helped them. But the flip side, I was just thinking, David, of medical professionals reluctant to seek treatment is, and you and I talked about or emailed about this, is this idea that we can be reluctant to ask questions, really sensitive questions that we feel that we might have to go to the medical board or report people, like substance abuse questions or impairment at work. I think to have a physician, for example, tell us that he or she is, impaired in some way at work, and then we're thinking we are going to have to report this and what that might do to the person's career. I think it's, it goes back to this whole countertransference thing. I think the most difficult people to treat for me, for sure, are psychiatrists and physicians who've had addiction. And you would think like, oh, I'd be an expert in that, but they touch so many buttons that I have to just constantly be checking in with myself. Like, okay, am I doing everything in the interest of this person and not like avoiding things because it's touching painful things in me?
Yeah, that was actually, I read some articles on treating celebrities, powerful people. And one of the things that came up is the danger of not asking questions that the person may feel are uncomfortable or embarrassing. Mm-hmm. And I think I get it. It's like that's a good example of how when we get impacted as providers thinking about this person, do we get impacted in a way that leaves us operating in a different way than we normally work? Maybe not giving as much empathy, maybe overly letting them run the treatment, not giving them the treatment that's the best treatment for them that we would give them under other circumstances. Mm-hmm. And there is this like uncomfortableness with the questions we would ask, like are you having any sexual dysfunction? Would you ask that to, some person that you look up to for various reasons? Yeah. I think also when you said, what do we document? I've chosen not to do an EMR for that reason, because, and not have it in a cloud, right? Document sparsely,
Yeah. And do you tell people that? Do you give them a heads up that, hey, something different about my practice is that this is, your information is not going in the cloud on an EMR?
I think I mentioned that on the podcast. And so I think, because if you're like a flight pilot, like you may not want any trace record that you've seen a therapist. Mm-hmm. I think that there is so much stigma about psychiatry, about psychotherapy. I don't know if I saw a therapist, if I would want my information on some cloud computer. And so when I started my own practice here in Florida, I was like, I'm just not going to keep records in a cloud, Mm-hmm. So.
Yeah, I would think that would give your people some comfort.
I think so, yeah.
Because, people often ask me, not just VIP patients, but, hey, do other clinics and hospitals have access to your records? And I say, oh, no, I'm just me. And they just great relief. People just like, oh, good.
Yep. Yep. And then I was reading about kind of like, do medical directors justify this kind of allowing the VIPs to be in their system? And, basically getting early treatment is how they would characterize most of the VIP treatment that they were giving, or like quicker treatment. Interestingly, when I was in California, I was well known in the university. And so I could walk into the ER and be seen within like 5 minutes. And I needed to do that one time, and it was very nice. I don't have that privilege in Florida. Or like, I have a list of doctors. I have doctor privilege. I have a list of doctors I could reach out to and ask questions and get an answer. Like, it's a real privilege.
Yeah.
And
but then you wonder too, there's the whole kind of over treatment, or just I've experienced people calling me, hey, would you see me? And VIP patient, I bend the rules. I see them in the evening or at work, at the end of the day, but then I'm tired. I'm not my best me. And there've been times when I did, something special for a quote unquote special patient. Afterwards, I thought they did not get the best of me because, I added them on at the end of the day. I came in on a day off. I did a video session when it would have been better in person, but they wanted it video because it was convenient for them. So yeah, I think it's a double-edged sword to have this sort of, privilege to be able to get in and be seen right away. And people are like, oh yeah, David's going to come see me, or Craig, but then, you're going to get the best care. I mean, maybe not.
Yep. So, I think it can be, sometimes expedited care and sometimes sort of like that special care is not always the best care. right? Especially like if it's expedited therapy. It's like, okay, you're a very highly, oh, I had this patient recently, super high functioning. Like if you were to read this person's CV, just would blow you away. And this person described going to 3 different therapists. And after 1 or 2 sessions, the therapists were like, hey, I think you're doing great. I don't know if you need to go to therapy. One of the therapists wanted to be a friend of this person, and they became friends. And I think because of this, it's like because this person is a very high social EQ person, they hide their distress so much more. But through micro expressions, I see it. I see it flash on their face. But otherwise, like the majority of their affect that they sort of put out to the world doesn't seem congruent to the level of the distress that they describe or that you can pull out. I don't know if you've seen that, where like because of their high social EQ or because of how they are, it's like almost harder to see the true distress. Do you know what I'm talking about?
Yeah, yeah. I think, part of being successful at anything is being able to fully step into that position no matter what's going on underneath. And we all do that. We carry our personas around, and I did that when I first got evaluated at rehab. I'm like, hey, do you know I'm a doctor? I'm an addiction specialist. Like, can you see me? Can you recognize this? And it took her a while to peel back to the me that was not this sort of persona that I was wanting her. I wanted her to evaluate my doctor persona, not what was underneath.
Yeah, that's interesting. It's like we can as well like want people to immediately identify us as like special, which of course we do. Like if you're listening to this and you're like that, it's like, yeah, that's very normal. We want attention. We want to feel special. That's like something all my kids feel, right? And that doesn't really change when you become an adult too much. Maybe you get a little bit more sophisticated on how you communicate it.
Yeah. I once had kind of the opposite experience where I went to see a psychologist, and at the very first session, I came in and I think she just didn't put it together who I was or whatever. Not that I'm any big thing, but when she figured out within the first couple minutes that, sort of where my position in psychiatry and stuff, she got so flustered. She started saying, I'm so happy you came to see me. I'm so glad. And she was just so deferential, and it really turned me off. I never went back. Like I felt like she tiptoed around. It actually reminded me, just another thing popped in my head once is I once went to primary care doc with some pretty terrible symptoms, and not to go into tons of detail, but really I needed a rectal exam, and the PA wouldn't do it. I think because of I was a physician and a male, and I could tell she thought about it and she didn't do it. And later it turned out I had to get one in the ER, but I know she treated me differently because I was a physician. Like I got undertreated. And it's much like that psychologist when she thought, oh, Craig Heacock, blah, blah, blah. She didn't give me a genuine eval. She just kind of fell apart and gave me sort of softball chat session for the first thing. So I didn't get what I needed from either one.
Ah.
And well, I don't even.
I think that what you're describing is you want competence, and you want to be treated like they would treat anyone else. And my PA listeners will be happy to hear that you wanted a rectal exam from them. Okay, that
or at least I wish I got one. I think it was simply because I was a physician and, maybe some other reasons, but yeah, both of them undertreated me.
Yeah.
I think they're both like, ooh, we should, okay, well, we'll just not really do anything.
Yeah.
And I wish they treated me like a regular person.
Yeah. No, I think we desire to be seen and to be understood. And sometimes I think when people get kind of like this cloud of, wow, this person's really special, then they kind of like maybe exit out of their ability to be present and to do the work that they would normally do. Mm-hmm. You get like distracted, internally focused, kind of self-critical maybe, or just like overly, it seemed like with that therapist, congratulatory or like deferential, right?
Yeah. Yeah. Whereas the psychologist I ended up with after her, I could tell he just treated me like anybody. He just treated me, I just felt, he wasn't wowed by that I was a physician or anything, or that I was a psychiatrist, he was a psychologist. He just treated me like a patient. And it was such a relief. I think that's the kind of the flip side. Some VIP patients want to be treated specially, but others just want to be treated like a regular person. And I think they might worry, am I going to get special treatment just because of who I am, when I just really want to be seen and cared about as a person, not because I'm the chief medical officer or because I'm a singer.
Yeah. Oh, that's what they get a lot of their life too, is they get this deferential treatment, not because of who they are, not because of their innate gifts and abilities, or maybe because of their gifts and abilities are, like if they're an artist or a singer, maybe because of that or their fame. But I experienced that the wealthy people just want to be seen, and they don't want to be seen and appreciated for their wealth. It really is a huge turnoff. And so there's kind of like, we want to be seen as human. And this is where like kind of working through our own countertransference, I think, can be so important. Like, hey, there's this person I'm treating, like help me work through this feeling that I have with this person, which is different than when I work with most other people. How do I make sense of this? How do I overcome this? I think envy is another experience that famous people, that wealthy people get from other people. I've had clients whose brother-in-law, sister-in-law want special treatment. They want money. They want, and it just drives a wedge in the family. And it's envy. It's essentially envy that's driving it. And then the envy and the anger from the envy doesn't get consciously registered in those people. And so then they direct that anger at this other person. Oh, this other person is angry at me, or, they label the person as narcissistic when they're actually very gracious and giving in every other domain of their life. So sometimes envy and unconscious envy can drive us away from other people. We can't celebrate with them their successes. And I think that's something to pay attention to as well in ourselves, which is a little bit harder. It's harder work. I think when we feel competitive with another person, I think that's harder work to do. What do you think?
Yeah. Yeah. I guess I'm trying to think if I've felt competitive with people. No, actually, I've kind of had recently sort of the opposite thing, where a couple psychiatrist colleagues of mine have become my patients, and they both just struggled terribly during COVID and burnout and depression. And so I felt like these were two people that I really respect and count on, even referred to. And then to have them kind of, go down, I felt really not competitive, really demoralized. I thought, oh my gosh, like two of the best psychiatrists I know are going down. And I'm treating them. And that's so scary to me. I felt honored they wanted to see me, but I thought, okay, I feel like mental health, often in the last year and a half, a lot of us have felt demoralized and like there's just too much pain. And now these two different people are coming to see me for me to try to help them. And I feel like I'm barely keeping my own head above water. And so it was this, it felt good to have them want to see me, but I also thought, oh no, like if they're going down, like, am I next? Like, and who's going to be there for me? Who can I go to? Because I feel like the last man standing.
Yeah. Well, I think there's one thought right off the top of my head is we're not going to be envious of people struggling. The envy comes when they're feeling better or their successes, and or when they come in and they've been very successful in a domain that maybe we want to be successful in. So I think what you're describing is also common. It's like these are people that you look up to, and it's like imagine you're in the trenches fighting this battle, and then the people that you expect to be by your side fighting the battle come in and they need, they need you to like pick them up and carry them. And so, yeah, there's like this feeling of like, wow, how are we going to keep going as a profession if like these people who are people I really look up to are struggling so much? It's interesting. I know a person who would come in and probably voice their struggle. And then when they go back out into life, you would never know. You would never know because they cover it so well, and I think as like, there's this thing like the most popular kid in school is probably the best liar. Yeah. And as your social EQ, IQ go up, like your lies become a lot more convincing. And essentially that's what we're doing when we put on that very strong social veneer to do the work that we do at times when we're feeling awful, is we're putting on that social veneer. And I think that's why when you humanize yourself and bring them into that, where they can be okay falling apart in front of you, I think that's why it's so connecting. And often the people who are supposed to be holding it all together, they don't have that place they can go to be completely raw and completely themselves. And that's so healing. So I would just encourage you, man. I think that is awesome that you are able to provide that. And
yeah, thank you. Have you noticed this, David, in the last year? I've noticed more people, maybe it's just because it's just been such a demoralizing last 12 to 18 months, but more people come in and they check in with me. Like, that didn't used to happen much, but people, how are you? How are you? And, and really wanting to know, not just sort of in a polite way, but a lot of my patients have been just genuinely concerned, like, am I okay? Am I going to be there for them? And it's very sweet, but I also think it's maybe a marker of the times. Yeah.
Yeah. I've had a number of patients who authentically, caringly want to, and have concern. And this one person I've treated for like 6 years, like could tell something was off one day, called me out on it. And I was like, you know what? I've been treating you for 6 years. You deserve to know the real answer to that. So I told her, and she was more than happy to give me a little bit of therapy almost, which is unusual. I mean, 6 years, right? I think it's like,
yeah, but you help her when you let her help you. What a gift.
I think so. I do. I think she really was honored that I would tell her the real story of what was going on. And, like these are real relationships, right? So the thing about treating people who are psychiatrists or therapists is they don't want the rehearsed empathic expression. Like, it's almost like their bullshit meter is so much higher, So it's like if you just say something that's like the normal pat sort of, imagine reading all the textbooks and now you want treatment. And you also don't want someone to say something that's not true, right?
Yeah. It is one of the cool things about seeing therapists. Yeah. And just mental health people that you're right. The bar is up, but the bar is up for genuineness. The bar is up for just like true connection. Because, what are therapists? We're professional connectors. And when you're seeing someone who's a connector, yeah, right. You can't fake it. You can't dial it in. So I see a number of therapists, and actually they're some of my favorite people to see. And they're kind of VIP in a certain way in my mind, because I feel like when you help a therapist, you help a bunch of people. It's just a big spill down effect. So I definitely feel myself kind of raising my own bar, for better or worse, when I see a therapist, thinking like, okay, I need to do everything I can to help this person, because this person works with so many other people. Like, there's just such multiplicative effects if I can help that person.
I think I think we have some commonality in our just the connection being the key aspect. It's like you want a real connection. I remember with one of my therapists saying to her, I just sometimes I worry, like, are you just saying these things because you've learned how to say them? And she had a really good answer. It's like, she was like, this is a real relationship, and the stuff you bring up affects me, and this is a real relationship, and that kind of stuck with me. Like, this is a real relationship. Like, this is not just, I know I'm paying this person a lot of money, and but it was. Go ahead.
I'm sorry. I wish there were a word that we as psychiatrists, therapists, doctors could use to tell our patients how we feel. Because, it's like, I care about you, I like you, I'm fond of you. But it's different. Like, we need a word, like, for the people I've worked with intensively and seen through their own darkness. Like, I have a love for them. It's not love in the traditional sense, but in fact, my wife's a therapist. She's like, asked me once, do you think you can love your patients? She said, because I think I love a bunch of my patients. And I said, yeah, it is. It's a kind of love. But it's not, we don't have a word for it. It's almost like the Eskimos have, or the Inuit have like 40 words for snow. We need some word for this like deep affection, respect, love, loyalty, admiration that we can have for people when we work deeply with them. And I wish we could use that word, because I'm often finding like people are questioning, is this a real relationship? Do you really care? And I'm always struggling for what's the right, real way to say that they can hear and feel it.
Yeah, it's sometimes hard for people who aren't therapists and psychiatrists to understand that, like, we can both be paid for our work, but also do it for free, or be doing it for free if we, if we didn't have bills to pay. Like, it's like the work, the therapy, like, I love the connection so much that I would do it for free. But some people can get fixated on, well, you're doing this because I'm paying you. And I think the way that you described it right there was perfect. It doesn't need one word. It's like, it's that struggle for a word maybe that's good. Mm-hmm. Right? Freud said therapy is a cure by love in one of his letters. And some of my analyst mentor said the patients that did the best under Freud would have over to his dinner table. He would go on long walks with them. That not the normal boundaries we imagine, right? Mm-hmm. And the patients he would do the worst with are the ones that he would have like a lot of negative feelings towards. Anna O, right, is a story of like this person that there was this huge connection between the therapist and this person, and the therapy was kind of ended, and the therapist went on a second honeymoon with his wife, which might have been like a sublimation of sorts, because there was real love that was forming between these two people. So we're human, we have love, and yet we have boundaries because we realize that's what's best for the person. And the boundaries are the same for VIPs or normal people. It's like, this is how much I charge, this is how long the sessions are, this is when the sessions take place, this is how I work. And I think staying in that frame allows for us to maintain, I am here for you, and first and foremost, and my attention, my thoughts are towards you during this time. Because it's easy otherwise for us unconsciously to collude with what is best for ourselves, I think, which is maybe the darker side. I could read a couple of these stories and see what you think. Michael Jackson's doctor was convicted of involuntary manslaughter for prescribing propofol at the request of a patient to help him sleep in 2009.
Yeah, he had his own personal physician giving him IV propofol in his house. Yeah. And
just for those of you who don't know what propofol is, it's used for surgery to keep someone asleep. So the idea is if you titrated someone right, it would put them to sleep no matter what. Yeah, okay, here's another one. Joan Rivers' clinic doctor took responsibility in a malpractice lawsuit after the comedian died in a routine procedure due to the doctors being overwhelmed by the star's presence. I'm laughing, but it's like horrible. It's a laugh of uncomfortableness. One doctor took a photo of Rivers while she was on the operating room table, which is a major violation of protocols in 2014. Steve Jobs refused to let his doctors remove a pancreatic tumor, hoping to find alternative medicinal remedies. By the time he finally gave in to the physician's request, the tumor had spread out of control. So that's an example of not kind of going along with standard of care and thinking that you're going to be able to find like some super treatment, which I've seen as well. Like I'm going to spend exorbitant amounts of money to have my brain scanned. And it's like, no psychiatrists across America, or the vast majority, 99.99% of psychiatrists don't do that. And there's probably a good reason why we don't do that.
Yeah. Yeah, I don't know what made me just think of this. This is a sad but telling story. I had a VIP patient years ago, which actually, I had never thought of her this way, but I'm calling her VIP because she was so unbelievably beautiful and charismatic. Like she was some like superhero, superpower of just like beauty, warmth, and charm. And I only saw her a few times, but I remember she came into my office once and she said to me, I need Xanax, 2 milligram bars, 2 a day. And I thought, that's insane, because I knew she had a history of addiction. And I ended up writing her the script and she walked out and she left. And I remember thinking, she's going to die of addiction because people cannot say no to her. And I actually found out years later she did die of addiction. She died of an overdose. And it was really powerful for me to think, like, there I was, like, literally writing her script and thinking, this is insane. But she was such a powerful force. And then me also thinking, like, this is going to kill her. Like, this superpower she has over people to just, like, get them to give her what she wants. And, I mean, it's a kind of an embarrassing story to share, but I think I'm sharing it because it's going to happen to people who are listening. There's going to be people who come in your office, and whether they're famous or doctors or whether they just light something up in you, and they're going to potentially ask you to do things or to write things that part of you knows you should not do. And you have to take a deep breath and ask yourself, why am I doing this? Because sometimes people get under our skin or touch things in ways that's only later, when we're rowing or biking or running and going over the day, and we think, oh, that's why I did that. That's why.
So because you shared that story, maybe a provider out there will be more consciously aware of how someone's beauty is influencing them, or charisma, rather than it unconsciously registering, Because I think we can be unconsciously driven to things. And then later when you're like out exercising, you're like, why did I do that for this person? I would never do that. And so I think it's important to tell these stories so that we can think through, well, what would we do? What would we do if we were in that situation with this incredibly beautiful person in front of us? Like, how would we treat them differently? Would we treat them differently? Mm-hmm. And what boundaries are good boundaries? I've had a couple patients who have had boundary issues with other male authority figures in their past, because they were beautiful. And it's almost like they're waiting for you to have that boundary violation with them. And I think the treatment is really powerful when you don't, and when you respect, like, hey, I'm providing this treatment for you. Dr. Tar would say, I shake hands at the beginning of treatment and at the end, but between that, we don't touch at all. So having the normal boundaries, not sort of changing the way that we do things with patients just because they're lighting us up in a certain way. Yeah, it's a good reminder.
Yeah, I think it's so important for all of us to continually remind ourselves. I like that, David, that am I keeping the treatment frame the same? Am I having the same boundaries? And if I'm doing anything different, and all the listeners will be tempted consciously or unconsciously at times to do things differently, to ask yourself why. Like, what is going on right now? Why am I doing this? This is not something I would normally do. Like, what is happening right here inside of me? And that can be a great learning point. And it's an ongoing thing. Like, I've been doing psychiatry a long time, and I still find certain people, for certain reasons, just get me acting in different ways. And I have to stop myself and say, wait, what am I doing? Like, what is this? Why did I just agree to that?
Yeah. And that's the beauty of being interpersonally, sort of questioning of, like, what is this unique sort of way that this person is influencing me? How do I bring meaning to that? How do I have some compassion for myself in the midst of it? And how do I sort of come back to be centered in who I am and how I operate. It's good, man.
Yeah.
Yeah. I think we could wrap this up. Yeah. Any sort of final thoughts, final kind of things floating in your mind, like you want to get out there on this topic, treating physicians, treating famous people, treating VIPs?
Yeah. I guess the main thing I would say is, again, this is such a perfect example of how checking in, not just with yourself, but with other people. Like whenever there's a patient or a session that just you're asking yourself, what was I doing? What happened? It's so great to check in with a colleague, to write about it, to get some supervision on it. Psychiatry is such an isolated profession. Most psychiatrists work alone, and most of us are seeing people all day alone, and yet we're facing these really difficult situations and things getting lit up in us. And even like we're doing right now, just kind of processing stuff, like this is so great. And I think the more we, again, are aware of when we're acting outside our bounds or when people are getting to us, but when we're able to talk about it and share it with somebody, like this is how the learning happens.
Yeah.
It's, voicing our doubts and being vulnerable.
Right. Because I think a lot of people are surprised when someone like Craig talks about these things, who's been, a very experienced psychiatrist, and they're like, wait, like what? Like, how does that, like, I thought everyone else was different than me. I thought I was the only one with the insecurities. And a lot of my patients feel that way. A lot of my patients feel like I'm the only one with the insecurities. I'm the only one with the imposter syndrome. I'm the only one here. Why am I fighting all these negative thoughts? And I think it can be helpful to hear, like, hey, we all have countertransference across the board. Everyone does. And it's through supervision, it's through talking to colleagues that we kind of move out of it.
So I'll call in your Xanax 2 milligram just after this episode.
Thank you. I would appreciate you prescribing that to me across state lines as well.
Okay.
Which could.
What did you want? You wanted like 5 a day.
Gosh, I may have catatonia. I may need 20.
Okay. All right. Done deal.
Okay. And I will. I don't know what I'll do.
This is fun to talk in the middle of the day, because our last conversation was like 11 or 12 o'clock at night my time.
Oh yeah.
Yeah, and you were saying, "Oh, I'm a night person." I'm like, "Oh, I'm not a night person. I feel like I'm more coherent today, even though my voice is scratchy."
Okay. So if anyone wants Craig to come back, talk about his MDMA trials that he was a part of, why he left the MDMA trials. Am I allowed to say that?
Yeah.
Did you leave the MDMA trials?
I did, yeah. But mostly I left because I just wanted to spend more time and energy on my podcast.
Okay.
Because Back from the Abyss takes a lot of time, and it's just such a labor of love, and it's so meaningful. So that's the main reason.
So go check out Craig's podcast. If you want us to cover any other topics, let me know. And we'll leave it there for today.